We aspire to improve lives of those affected by PANS and PANDAS and related encephalopathies. Our biggest aim and our goal is to create usable tools such as webinars such as this, our toolkits, information on our website, lectures, all sorts of different programs to empower all of you listening in with information, because we can't always be with you every step of the way as much as we'd like to, but we'd like to be able to help educate and create awareness around this devastating but treatable disorder, so that you can go out and assist your patients and assist your children and assist yourself if you're an adult patient with this disorder, or your students. And not only help them, but help also spread the word about what PANS PANDAS is and how it can affect lives. So in doing that, we have 5 core audiences: our general public, families and patients, schools, public policy, and our providers and researchers. So of course we have our website, we do lectures and toolkits and everything that we have on there that we try to keep as free as possible with no charge. So far we haven't charged for anything, and I really like to keep it that way. Can't guarantee it, but you never know. And we do in-service lectures, all sorts of things. So family support is really important, and it's sort of our mainstay of what we do most. We have our family stories. We'd love for you to share your story with us, because what better way to spread education and awareness is from your story, from the mouths of the families that are dealing with it. We have one-to-one support groups, we have Facebook groups, and eventually we'll get it up and running, our chat group. Our schools, we're a little down for the summer because it's not in session, but we've already been booked for our in-service lectures starting in the fall, which have been a really resounding success. So if you have an IEP, it's a lot easier to get because it can be part of your education package. Your teachers and providers should understand what it is at school. But with 504, we can do other things, and we offer them for free, so schools can't really say it's a budget thing. And in an IEP, they're not supposed to, but that's just an aside. Anyway, so we do public policy, and we support the boots on the ground. We cannot be in every state, so we have people do it, and then we have some resources like their state pages to sort of get up and running, so they don't have to create the whole wheel themselves. And of course, we support our providers and research in many different ways with toolkits, handouts, and a lot of things behind the scenes that we don't talk about on the daily, but we're always active in that environment too. And one of the things that we've started this year is our webinars. Thank you for coming today. And if you've missed any of ours in the past, we do have all those links up on our website. We're working on creating a really big, broad library of them with different categories: treatment and scientific updates, behavioral health, integrative medicine, school support, and of course, family and patient support. So today, dun, 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 we have one of my favorite people and providers, Peggy Chapman. She is an RN, and she will be speaking on psychiatric medication strategies for children with PANS and PANDAS. Peggy is a clinical nurse specialist. She's board certified in children and adolescent psychiatric nursing. She received her Bachelor of Science in Nursing at Creighton University in 1976. She graduated from BU with a Master of Science in Nursing and was certified as a clinical nurse specialist in 1993. She has worked in various capacities in the mental health world in Omaha and the Boston areas as a nurse manager of child and adolescent and adult psychiatric units. She has been a therapist and done psychopharmacology for all ages since 1998. She recently closed her private practice in Hingham after 16 years to quote unquote retire, which we all begged her not to, and we know she has no desire to retire ever because she wants to keep helping all of our families. And in doing so, she's joined with Melissa McCormick, who's a wonderful pediatrician in the Boston area, and Sheila Gouch, who is a social worker and runs a wonderful school in the area. And they opened the Bridge Consultants. So they work together to use all of their experience with these neuroimmune disorders. And they diagnose and treat children with neuroimmune disorders and their treatment-resistant mental health symptoms. So I'm really excited that they are this wonderful group working together. So please look for them on the page that Peggy webinar on is a direct link to the bridge. And then if you look in our provider list, it's in there as well. So today she's going to be speaking on, of course, psychiatric medication for PANS PANDAS. And I'm so excited for everybody to listen to what she says. She's truly compassionate. She understands the ins and outs of this world that we reside in. And we know that some people do better or worse with psychiatric medications, and therefore there's sometimes some resistance to using them, but she really is so compassionate and so understanding and understands the medicines and how our children work and this neuroimmune condition that we're working on. So I'm really, really grateful that she's taken the time to speak. And I will stop sharing. And she will start.
No, thank you, Gabrielle, for that lovely introduction. I'm so excited to do this with you and just see you again and spend some time chatting. So as Gabrielle mentioned, I've been doing this a long time. My first patient I treated was 1998, shortly after Sue Sweeto published her seminal article on OCD strep pandas. So I've been doing this a long time, seen a lot of growth in my own understanding of the illness, the whole development of the problems, and real expansion into what I'll call neuroimmune neuropsychiatric disorders. It isn't just PANS PANDAS, although PANS as a sweeping kind of entity covers most of those things. A new version, of course, is long haul COVID, because 20% of people who have COVID in the long haul group, or of people who have COVID, 20% develop neuropsychiatric disorders. That actually matches the Spanish flu. It matches data from Europe. It matches other SARS viruses in the recent past. So I'm going to talk about a lot of general principles I've learned in medication. I probably should write the brochure or book around this. This is kind of the beginning. And for all this lecture, children refers to all children, adolescent, young adults, and PANS, PANDAS, and other neuroimmune psychiatric disorders. A basic overview of what medications are changing in the brain, symptoms and diagnosis and classes of medications are used to treat psychiatric symptoms, the area of the brains that are targeted in each class of medication, additional medication and supplements that might be helpful, and new books that might be of interest to you. The things you could learn to read, I'm sure many of them have them already on your shelf. These are newer ones that you might not be familiar with. First of all, anyone with PANS, PANDAS, and other neuroimmune neuropsychiatric should be considered as an atypical neurobiology. In other words, if you have PANS, PANDAS, you are not unlike people with an autism spectrum disorder or some genetic conditions and epilepsy. How this translates is that you have to be very different in your approach with prescribing than a typical, say, psychiatric practice. I'll talk about that a little more in a minute. And neuroimmune neuropsychiatric disorders are first and foremost a medical condition. However, the reason you need a psychiatric provider like me is that the psychiatric symptoms of these neuroimmune disorders are very debilitating. And that's what brings you to PANS PANDAS world. It isn't the medical condition, it's the neuropsychiatric symptoms that you are living with. There is no, unfortunately, one pill or medical treatment at this time that is likely to fix medical or psychiatric symptoms so that you can avoid psychiatric medications. If a child is young and you've just started a PANDAS, like they had strep throat at 5 and they're crazy by a week later, you might have a chance to avoid psychiatric medication. But for many, many people who have entered this world, until we can get doctors more on board and trained and accepting, we're still dealing with a lot of chronic PANS, PANDAS conditions that as you go further and further down the road of inflammation, more and more neurotransmitters and neuropsychiatric conditions change in your brain. And so this is where you're going to probably need psychiatric medication while you're trying to heal the brain. And then once you're in a healing state, psychiatric medications are actually tapered and discontinued if possible. Psych meds, I say to parents a lot of the times, are like a Band-Aid on a gaping wound. They stem the blood flow, they might help prevent sepsis or death, but they're not going to stop the PANS illness. not, so I don't pretend that the psychiatric meds are the answer in any shape, way, or form. And I think this is what you have to understand when you're getting psychiatric meds. It's not going to fix it on its own. Neither do the medical treatments often fix it just on their own. In a person with atypical neurobiology, which are all these people, a prescriber must dose low and slow in any med trial. And you may have to argue for this. If the doctor says try 10 Prozac 1 week and go to 20 the next week, that may be a little too fast. That would maybe what I do with a generalized adult depression. But in children, particularly in kids with atypical neurobiology, that may be too fast. And side effects in this group occur at non-therapeutic levels. In other words, there's sometimes you can expect an adult with a regular depression might do fine on Prozac 20. You might not get past 5 or 10 in this group. There is no simple solution. By the time you arrive in this world, you are suffering from the loss of your normal life. And in my very biased opinion, if you are trying to avoid the use of psychiatric medication and only hoping for medical interventions to treat your child, you might further delay your child's return to normal life, or at least some part of the normal life. So for example, if they're really, really struggling to get to school, and some anti-anxiety, antidepressant / OCD med, which they all run together in one, might give you a help to get the child to school and stay in school, that might be something you're missing if you delay. And by the way, many psychiatric medications diminish the impact of neuroimmune inflammation. So for example, Luvox was being used in COVID in hospitals to lower inflammation of patients who are seriously ill. Hospitalizations are traumatic for everyone and can often be avoided if you're medicating kids with severe agitation, anxiety, mood dysregulation, eating disorders, and harm to self or others. There's many a phone call I'm at when I'm saying, you either try this antipsychotic or you're probably going to be hospitalized, and I don't see any other way around it. And it's very hard for parents to make this decision, but I'm working my butt off, frankly, to keep your child out of the hospital. But I'm only able to do what I know what to do. And I guess I feel like I have a lot of experience to say this with some authority, that it's worth trying the med and getting over your fear of side effects than ending up in emergency room or hospitals, which are horrible, as most of you can attest to. Those of you who suffered from psychiatric providers who are not versed in neuroimmune disorder, I apologize for all of them. And some of them are frankly a serious embarrassment to my sense of being. However, please be cautious about applying those experiences to all of us who prescribe medication. In other words, not everybody out there is totally unempathic, just opening their prescription and not listening to you. But that has been going on since I've been working 45 years now in this business. And you're always going to run into people, like you do in all professions, that are less than great. And sometimes you have to keep searching, and it's really hard and it's really a lot of work, but it's worth it if you can get somebody, at least the person who listens and who collaborate with you, because many of you are very educated and know questions that are good to ask. And you have to have somebody, frankly, like me, who can tolerate lots of hard questions and who is engaged in hard questions. And even with my experience, there's no crystal ball or Bible how to do this work, whether it's PANS or traditional psychiatric diagnoses like bipolar or schizophrenia. A high amount of collaboration, as I mentioned, is really key to a successful experience. Even if the meds don't work, you're not quite as whacked out or weirded out about doing it. Side effects in the atypical, neurotypical people are often listed in the infrequent and rare categories. So when someone calls me and says, they have a rash from this med, I go, really? Well, let me look that up, because I don't doubt you. It's just I don't remember hearing about it. And sure enough, there it is. But this can lead prescribers to dismiss you as the side effect is not connected to their medicine. Somehow it must be somebody else. Go to see a dermatologist, go to see your primary care. And I certainly say to people sometimes, go get that rash checked out. It doesn't appear to me by sending me a picture or looking like the kind I might expect with a side effect. And also it's so rare that it's worth to know if your child just happened to roll in a patch of poison ivy or something. But it is those side effects we have to pay attention to in this group that are often not common. And recognize that some medications have so many side effects, it's hard to know if the med is causing the problem. If you have never looked at the package insert for Tylenol, it will horrify you, especially when you've been giving it to your children all along, about how many side effects can be involved with Tylenol or aspirin, but Tylenol is a good one to look at. And the side effect that you might be worried from can be from a PANS illness and not the medication. Even though you just started, say, Zoloft, an antidepressant, the side effect actually can be a flare of symptoms due to members of your family having a cold. And one of the jobs that's very hard for parents is they want to talk to me about the med and how much it's causing a side effect. And I want to know a lot about the current history of what's going on in the family in terms of illness states, exposures, because in order for me to make a good assessment to take somebody off of med, unless it's a dangerous side effect, we really want to know that there's a high enough risk to take them off the med, because it can take a long time for some of these meds to work. And if you stop it, then you got to rebuild back up. The best thing to do if symptoms are not clearly from the medication or PANS symptoms, or you cannot figure it out, and I use this a lot, is to stop the medication, but always under the direction of a prescriber. In most medications, stopping the med can quickly allow you to see if the issue stops. But please do not discontinue a med without being instructed how to taper and discontinue the medication. Many parents will tell me, oh, I stopped the guanfacine or the that's clonidine, Tenex. Those are blood pressure medications. If I have you on a high enough dose, you can create some wacky behavior in the blood pressure zone that is going to make your child feel pretty awful if you just stop it. Some of the antidepressants, if you just stop them, particularly, and lorazepam type, the benzodiazepines, are actually going to create a lot of anxiety. Or at least you should know that when you stop an antidepressant, even when I stop one, well, I try and taper down. But if I have to stop one, I know what anxiety I might be able to talk to you about what you might expect that you will be experiencing. There are some meds like Strattera, doesn't matter, and stimulants, doesn't matter what you did with them yesterday, as far as you can stop them today, and they taper out very slowly, so it's not a problem to stop immediately. A prescriber, and very importantly, all parents and patients must expect that in this illness state, that multiple medication trials may need to occur to achieve success in treating the symptoms. You may begin to feel like you're running a pharmacy. I hear that phrase a lot. And prescribers, though, can learn from failed meds. I do all the time. What may be occurring in neurochemistry of your brains, of the brains. For example, if I give a small dose of a stimulant, which I'm not as easily likely to do in this group, but let me say that they have had ADHD, they've worked in the past, and they've stopped. And I now want to try again, can they take a stimulant? Because it could help them a lot with their impulse management. But if I see a lot of agitation, I know I've hit the dopamine part of the chemistry of your brain, and it's in the wrong part. Now, the way we know this is also on the Cunningham panel. Some of you are familiar with this blood test, which talks about antibodies. It talks about excess antibodies attacking dopamine receptors. So as I show you later, if you attack the dopamine receptors, you mess up the flow of dopamine. So when I give a medication that promotes dopamine, like a stimulant, now I'm just adding fuel to the fire. It's like jet fuel on top of the fire. And that's informative to me, that this may be some of the areas I need to work around and or target in a different way. And even if your child has managed on a medication, I mentioned stimulants, for example, the same effect may no longer happen. I think one of the questions was, my child did a trial stimulant or antidepressants, I think the question was, and then maybe they didn't have a good response. Maybe they had a side effect at a very low dose when it was really helpful 4 years ago. This is because the brain chemistry secondary to the neuroinflammation is interfering with the normal transmission of what those medications are trying to achieve. If your child has gained a lot of weight, ask for the medication to be changed. This irritates me to no end. I get a lot of people in and they've gained 40, 60 pounds and no one has stopped this medication. And that is, to me, totally abusive. And so you do have to, my kind of limit is 10 pounds or 10% of increase in the body weight we start with, and accounting for their expected growth. So if you have a 7 to 10-year-old and it's over 6 months, you also have to track out what was their growth track, what would have been their normal weight gain over that period of time. And occasionally a joint decision is made between the family and I. When I say, I think we need to take somebody off of that because of weight or a side effect I don't like, they go, oh no, don't do that. Don't do that. Well, it's okay. It's okay. Please don't do that, because that medication has created a lot of stability in that child. Use of antipsychotics and some anti-epileptic mood stabilizers also require blood work, and medication can sometimes continue if the blood work is refused by the patient. If, in other words, if I'm required by my standards to get blood work on a kid with an atypical antipsychotic, like Abilify, which a lot of kids are on, and the kid won't do blood work, I can identify that, I can report it, I can record it, and the parent or the caregiver and I are agreeing that we're going to proceed anyway. That's with me documenting there's no side effects, symptoms of side effects. So you don't have to have blood work, absolutely, but you need to be aware that some by my profession require me to do certain blood work on certain medications on a regular basis. And some anti-epileptic mood stabilizers like lithium and Depakote and carbamazepine do require blood work because you can't monitor it really well without it, which would rule out those medications if your child doesn't do blood work. Over time, your prescriber should be getting height, weight, heart rate, blood pressure, even with telehealth. I often ask people to report to me what their vital signs at a physical was, or if they stopped at Express Health for some ear infection, you can write down those vital signs and give them to your provider, so that on telehealth in particular, we don't miss them. There was some change in the pharmacy world recently where if you don't have a height and weight within 6 months, you can't get a med refilled. That was a new one that just got thrown this last couple months. There's an inexpensive and accurate options, and Consumer Reports guide gave us some of those really great ideas. They're pretty inexpensive to get it for home monitoring. Finally, your gut instinct should be voiced to clinicians, even if it is opposing what is being suggested. I can't tell you, well, I can tell you that my mentor in functional medicine and neuropsychiatry was Paul Hardy. Some of you may have heard him years ago speaking in New Hampshire. And he always said, first, you listen to the mother. That is our golden rule here. And he taught me well. And even if I don't agree with the person, a discussion of what you were thinking about or why you have this idea is extremely informative to me, because you may actually not have communicated something to me that you're feeling, but I will be able to make the connection for you. And it's really, really helpful. Again, you have to have a prescriber who can listen to you and honor what your gut instinct. And if people say to me, no, I can't do that. Okay, but then I can spell out what the risks and benefits are of you making that decision. So we're all as informed as we can be. If you're avoiding psychiatric medication, please ask yourself, am I trying to avoid this due to my fear of a stigma of my child having a psychiatric illness? Many of you who have never been in the psychiatric world all of a sudden get yourself thrust into it. It wasn't like you had like one of my children had anxiety from very young and kind of grew, and separation anxiety, and we went to this anxiety. And it wasn't a surprise to me when it would prop up. But for many of you, this is a total change in your child. So it's pretty frightening to just step into this business. But I want you to ask yourself, are you fearing side effects without having never tried anything? And my question always is, would you say no to chemotherapy, which is riddled with side effects, if you said, if your child had cancer and you needed this for a treatment? And I think most of you would say, no, I'd take the chemo. So I'm asking you to consider that your fears and concerns may be getting in the way of your children getting some relief. So if you're avoiding them, then you're suffering. By avoiding the stigma, you may inadvertently be joining the people who believe that moral character accompanying behavior and decision-making by people who are supposedly more moral than the rest of us is the reason for their mental health problems. So you're actually joining the group that, as caregivers tell me all the time, do not leave casseroles on your porch. So many of you talk about, you don't get casseroles. And somebody just said to me 2 days ago, Peggy, I worked in this hospital for so long. I'm, a key player on my team. I've been home now in FMLA for 2 months. I've not gotten one wish of help, speedy recovery. What can I do to help you? And I have put in money and time for everybody else's illnesses and their families, and nobody has said a word about my situation. And I know you all suffer from this, but don't collude with the idea that it's dangerous to go to psychiatry, because now you're joining them about not delivering casseroles, I guess is what I'd say. Something you should provide the prescriber, even if they don't ask it, try and get them to take it. If they don't want it, then I'd worry about the prescriber. But they need to get as a complete intake as possible. They usually will do an evaluation. They're going to ask for medical history, neonatal history, religion, medication history, behavior, inventory, family history. If you can get a list from the pharmacy, they usually give you and print out very easily the last 2 years of prescriptions if you've been in a pharmacy, or you can get it from your old pharmacy. This is really helpful for me if you've had a lot of different med trials, or what dates you tried them relative to what symptoms you've got. And In the future, please keep a log of any medication you're on, whether it's an antibiotic or a prescription psychiatric med, about when you started it, what dose you were on, and why it was used, and when it stopped. That information is critical for somebody like me to understand the interplay between the medical and the psychiatric and choices. Like, for example, many stimulants are stopped because they had a bad reaction. Well, what that could be is they really had a bad reaction, or it could be what's called rebound, which is as the stimulant is wearing off, especially short acting or long acting that's not strong enough, they have this 90-minute of distinct agitation and aggression and just obnoxious behavior. And then it's like, oh, that's gone. Now they're back to their normal self without medication. That is not actually a side effect to be avoided. That's a medication side effect that can be adjusted for and gotten rid of. But many people will say, I've had a bad reaction, and then no one ever wonders what it is and never uses it again, when it could have actually been a good med, because the parent will often say to me, it was great in the morning, and then they were awful. And then they don't try it again. The other thing, it's really helpful for me to have, I'm not sure everybody else would agree with me in my profession, but I really like to have academic testing, neuropsychological testing, speech, OT, IEPs, 504s. All of this is really interesting to me because it really informs me a lot about how people are viewing your child, viewing you, whether they think they're getting the right supports in school, how PANS may or may not be influencing other medications that you've had. For example, things like histories of ADHD or bedwetting or sleep problems, those can be woven together to actually understand that maybe there was an early event of PANS that you didn't even recognize. Like if you had an anuretic event at 8 and now you're 12 in my office, that was probably an early PANS event, as Sue Sweeto would say to you always. Neuropsychological testing, also in the very beginning of all neuropsychological tests, in the report, they give a lot of early history that when you're in my office, we may miss asking, or I may miss asking about, that didn't seem relevant, but now I've got that information that's relevant to me. I just want to make a couple points throughout this talk about certain things that I no other category to put it in. So inflammation can contribute to a wide variety of psychiatric symptoms and influenced by genetic predispositions. So inflammation just doesn't come just from an illness. There's also genetic influences. There's environmental adversities, including stress. Stress is very pro-inflammatory. And stress has been huge in everybody in the last couple of years. And then a lot of people have gotten sick with illness. I'm not ready to state, as some of my colleagues would like me to, that all psychiatric conditions are related to inflammation, but I'm moving closer to that idea. And I'm always finding increasing amounts of things about depression, bipolar schizophrenia that are noting inflammatory markers. I just saw a headline a day ago about bipolar and part of the striatal changes. Now, striatum is part of the basal ganglia, which we're going to talk about in a minute. Genetic testing in psychiatry, this is another one people ask about, so this is my little bit on this. Studies have been shown in improved outcomes and compliance with medications when you can use genetic testing correctly. The problem is many of it's done through testing, but the people who are ordering for you or who are getting it for you don't know how to interpret the results really well. Just because it might be in the red column, for example, in one of the reports, doesn't mean you can't use it. You have to know what the red column means. And also, genetics do not always predict side effects. So, for example, in ADHD medication, it can tell me whether or not you metabolize dopamine really well, but it doesn't tell me if you're going to have appetite suppression or insomnia, although insomnia may be influenced by dopamine. But it doesn't tell me everything about side effects. You cannot predict them from the genetics we now know about. You can also do self-genetics, so you can do 23andMe or the other ones that are around. But I have seen some of these reports that are frighteningly scary. So one boy came to me with like a 15-page report, 4 sections, 4 pages, I think, were on bipolar. And he said, I have bipolar. And I said, well, let me see that. And I could not find anywhere in those 4 pages that they had it. They kept saying you could have bipolar if you had this presentation of these genetics, but he didn't have that presentation, except it went on for 4 pages to tell him about all the genetics he didn't have that would have given him bipolar probability. So it's not easy to understand some of this stuff. You do need somebody, in my belief, that's somewhat skilled in understanding this. So that's a sidebar there. But I know a lot of people are looking at this. Now I'm going to talk a lot about the brain. We're going to start with an overview. This is the front of your brain. This is the back of your brain. This is your motor cortex. This is where tics more emanate from. But down here, which I'm going to show you in another slide, is where we're really going to focus. But you can see the middle of the brain attaches to all these other areas. This is the area we're going to talk a lot about. This is the basal ganglia right here, but all this area around it is made of a lot of different sections. And very near here, very importantly, so basal ganglia is what we know to be attacked by the strep antibodies. Also the hippocampus, which is over here, the amygdala, which is right here. What's not mentioned here a bit is the temporal cortex here, which is where psychosis comes from. But if this area is inflamed, many dopamine tracks and tracks of transmission of neurotransmitters run right through this area. So if you have motor tics, you're in this area. If you have sensory issues, you're probably back here. If you have cognition issues, you're up here. But the amygdala is fight, flight, hippocampus is memory. So if this area is impacted, it can influence all these other areas. In a more finite rule, that whole brain section is made up of billions of nerves, and nerves have this axon and a sheath here, a extension and the axon, and then the cell body is here. And then here, these two cells are connecting. They connect through these branches from one cell to the next. So this is on the tip of a branch, and this is called the synapse, where neurotransmitters, those are the chemicals you've heard of, dopamine, serotonin, norepinephrine, acetylcholinesterase, glutamate, they transmit one to the next, and then they signal downstream, which I'll show you in a second. That's there now. Here's that one nerve hitting the next nerve and this synapse. Now, if I give serotonin, for example, Prozac, Paxil, Luvox, Lexapro are all serotonin transporter reuptake inhibitors. And I'll show you in a minute what that does. But basically, it's going to impact how serotonin up here is released, how it's taken up by this next cell, or how it's swept back into the cell that it came from and managed up there. So there's billions of these. You can't think fast enough to understand how much this is going on. Downstream, this is now I'm going to show you now this membrane right along here. And this membrane is now here. And here are the receptors. So here's serotonin. Here is NMDA, another one, glutamate, who you've maybe heard of, glutamate glycine. Glutamate, also known as monosodium glutamate, which many of you try and avoid in your soy and your Chinese food. It's excitatory, it can give you headaches. But it also is influenced by these little tubes here. These chemicals have to go through these tubes, and controlling these tubes are sodium, calcium, potassium, magnesium, particularly sodium, calcium, and potassium. And depending upon how they are charged, positive or negative, depends upon the opening and shutting and or the reception and receiving of all these chemicals. Now, you've ever had a kid who brings home a potato and they stick a wire in it and it lights up a bulb. That's a positive charge. So your body's electrical situation is heavily controlled by these natural, minerals, which is why you need to eat a good amount of them. And downstream, I'm not going to get into all this, but this is where your genes get expressed. So you have genes, here they are, but how they get interpreted and expressed in mRNA is what happens to you downstream. And this can be changed by different medications and by different nutrients and different gut health. Your genes dictate how you might have it expressed, but actual environment stressors, what you eat, how you sleep, changes the way these genes get turned on and off, and that's called expression of your genes. I mentioned these neurotransmitters. Dopamine is reward-driven and learning. Serotonin is well-being, happiness. Norepinephrine controls heart rate, flight, fight, and is a stress hormone. The transporters carry these chemicals across those membranes. The receptors receive those, and here's those channels. They're called voltage-gated calcium or sodium channels, and they influence the flow of those neurotransmitters in and out of cells. I'm just going to quickly go through some of these. These are for you to come back and read. This is dopamine, probably the key area that's impacted in PANS PANDAS. Dopamine is responsible for all movement. So any tic, any guttural, any blinking, swallowing, breathing is an action that dopamine regulates. Parkinson's is an abnormal dopamine regulation, but it's also extremely important in memory and mood, alertness, control, and pleasure. Very importantly, sleep, all these things. And here are some interesting things that I just found in a great 2 article in a psychiatric journal, but somebody is positing, and I think very accurately, the symptoms related to dopamine. So here's what you might see medically in dopamine excess. Notice dilatation of the pupil. I bet a bunch of you could hold your hands up about people who have dilated pupils in your family. Salivation, delayed gastric emptying, which causes stomach problems, causes stomach pain. Psychiatric, this is where hallucinations, delusions come from. Grooming rituals, there you go, that cleansing rituals, that would be your OCD. Hair pulling, thrill-seeking behaviors, self-mutilating. Some of these you're going to see repeated in different chemistries. It's not just always one. But this gives you a really good example for me and for you to understand dopamine is in hand here. So medications I might choose might alter dopamine flow. This is deficiency, restless legs, tremor, dry mouth, constipation, diminished ability for repetitive tasks. That would include picking up your clothes, brushing your teeth, combing your hair. Drowsiness, poor grooming, binge eating, which helps people wake up, kind of get going, excessive tiredness. Serotonin is a chemistry of learning, memory as well, but pleasure, pain, relaxation. It affects sleep, appetite, learning, relaxation, muscle contraction. 80% of serotonin is made in the gut and the remainder in the central nervous system. If you have an unhealthy gut, this is where people, especially in the functional medicine, integrative medicine, pay a lot of attention, because if you have an unhealthy gut, you have an unhealthy system of serotonin. However, the unfortunate part, as you all lived, is when your child gets sick, all they want is carbs and sugar. It's like something gets turned on at super speed, and proteins and healthy things that they might have eaten all along before are out the window. It's very hard in helping your child in this situation. But gut health ultimately is one of the big ones. Serotonin excess, obesity, hyperflexia, paresthesias, that's pins and needles, shivering, diarrhea, high pain sensitivity, meaning they're very easily bothered by pain, psychiatric panic attacks, psychosis, hypervigilance, brain zapping. That also comes from medications that manipulate serotonin, by the way. Serotonin deficiency, recurrent headaches, brittle hair, dry mouth. Brittle hair is also of omega-3 fatty acid deficiency. And psychiatric, higher aggressive behavior, high lethality, because when you are low in serotonin, you are really depressed. You are very hopeless. And I know a lot of kids, especially those with tick-borne illnesses in their teens, young adults, who are absolutely suicidal ridden and hopeless and all these things. Norepinephrine is connected to adrenaline. It's a neurotransmitter hormone. It affects focus and alertness. So some ADHD medications and ADHD medication and anxiety meds are norepinephrine related, but it also attends to attention, concentration, perseverance, recall memory, and epinephrine, which is right near it, is adrenaline. It's made from norepinephrine. So adrenaline comes from norepinephrine, so it's very connected. It is fight, flight in its boldest, biggest form. It affects your heart, whereas norepinephrine affects your blood pressure more. So they work in one doesn't work without the other. And epinephrine is excitatory, whereas norepinephrine, the precursor, is inhibitory. It dampens down and epinephrine excites. This is a couple other ones that you might see and hear about in some medications. Alpha-2 adrenergic receptors. These are blood pressure ones you hear about. This is guanfacine, Tenex, clonidine, which is also known as Capve. And through here, it signals as a calming mechanism. These are ones that often, if you use these meds, they make you pretty tired at times. And they also work on what we call secondary messengers. They bypass the dopamine system. They don't hit the dopamine directly. They just kind of go around it, but they go down the same pathway. When I talked about those genetic pathways in that one slide, it hits in later, but it avoids dopamine, direct dopamine, which is helpful. It treats ADHD, impulsivity. Tics are all connected here. The medications for tics, some of the main ones are guanfacine or clonidine. And so what happens is you're lowering the blood pressure, you're lowering adrenaline and heart rate, These are heavily used, galopsine, clonidine, to help your children be a little calmer and more reasonable, especially in what we call that witching hour between 4 and 6 o'clock in the evening. Norepinephrine excess, I won't go through all this again, but it's similar to some of the others you've already seen. Now the headaches are a little more violent, a lot more physical stuff, nausea, rapid breathing, tachycardia, which is rapid heart rate, low appetite, and restless sleep, hostility or hyperarousal, hypervigilance. This is more the fight flight events. Deficiencies, you're blunted, you're just barely paying attention to anything. In pain, but here pain that doesn't usually come from things is pain. There's a lot of pain in norepinephrine deficiency as well. Psychiatric is, again, more quiet, lazy. People think I'm lazy. They have a lot more brain fog, inattention, teariness. Other important articles, chemicals you might hear about: glutamate, GABA, a lot of these things. I'm not going to go over it. Couple other things to think of as brand versus generic. I'm not going to go over this all. These are things for you to learn about and read about if you can or you care to. Different kinds of medications. Okay, so I mentioned all this messaging through those cell-to-cell measures. And the other thing I want to mention is glial cells. So this is a whole new area of interest, and it's kind of revolutionized neuroscience at the moment. And even in COVID, this is the area that they think is causing a lot of the neuroinflammation. Glial cells are 4 kinds. I'm just going to briefly say that they either support and feed the cells or they destroy the cells. When they're hyperactive, they start destroying cells. They destroy synapses, those connections I talked about. They start chopping off those branches. And so you can lose abilities at times. One of the biggies is the brand new news of February 2020 that Epstein-Barr virus has a dramatically increased role in creating multiple sclerosis. And I see a lot of Epstein-Barr elevations, which is mono, of fragments still in people's bodies that we don't know where it's going to go, but we might now know it might be heading long stream downstream if you don't get rid of it and treat the inflammation to MS. Now, another thing I just want to show you is the next other thing they're talking a lot about is circuits, not just individual chemicals or individual synapses, but circuits. And I'm going to show you these fantastic pictures of circuits. This is one of them, which is green, blue is ascending, green is right to left, front to back. There's another one, this is white matter. These are nerves. This is, colored nerves, but that's nerve tracks in your brain. And between the two hemispheres, how it all meshes together. And this is really good. This is a fluid mapping. You see a lot of these. I'll show you one as to where things are happening. Hot, cold, green, red, blue signifies if there's overactive or underactive areas of the nervous areas. Stress. Okay, back to this. This one is now about depression. So depression involves a lot of the frontal cortex, your loss of concentration. When you find people who's really depressed, this area, which is your frontal cortex, where you think and cognition and wisdom, is shrunken in serious depression. And when you give an antidepressant, that enlarges again. There's a lot of hippocampus problems with depression because memory is poor, concentration is poor. I'm not going to go through all this because I'm running out of time, but these are things you can read about, the areas of depression influences. These are the bodies. I mentioned the frontal lobes, the hypothalamus, the hippocampus. Too much connectivity. Now, remember I started those circuits? In depression, they think some things have too much connect and other areas have too little. So in anxiety, for example, the amygdala, which is fight flight, is way too hyperactive. And the connection between the frontal brain and the frontal cortex and the amygdala is off. And high levels of inflammation are found in depression. This is about antidepressants. I'm not going to go through all of them. You may have some specific questions you want to answer. Zoloft, I'll just give my vote for that. If you're looking statistically at genetics, this is the one that is the least likely to have the genetic flaw that would get in the way with a lot of the other ones. These are selective serotonin norepinephrine. So they take a little bit of serotonin blocking, they take a little norepinephrine block, and you get things you'll find about Cymbalta, Pristiq. Some of you have used these. And then selective norepinephrine dopamine is Wellbutrin. So it depends on which match and which combo you get in a med. And then other ones, some of you are familiar particularly with trazodone, which is often used for sleep. And mirtazapine is also used for sleep and appetite and antidepressant. That's probably one I don't use enough or think enough about for kids with PANS PANDAS. Other ones I'm just gonna let you read about. And these are old style ones, but interestingly, you might still use something like amitriptyline for pain, or norepinephrine for bedwetting, or anafranil for OCD. Now, this is another option for depression. More and more kids are getting referred for this. The problem is still that only, it's really hard to find it for adolescents without paying out of pocket, but it's coming for adolescents. It's being tested now, but it's a very active for people 18 and over. This attacks connection. This rearranges the connection of a certain area they've targeted in your brain. And very importantly, this has been approved for depression. And recently, in the last year or two, it's been approved for OCD. It's kind of not like electroshock therapy, essentially, but it is targeted to shake up a connection and get kind of move around those neurotransmitters so that they rebuild in a more healthy manner. And some of you are asking me about ketamine. I've had some patients who've actually, before I met them, have used this. And this is an anesthetic. It can be very addictive. I've seen kids benefit and then they don't benefit. So warning, warning, warning. It may not be the answer you're all looking for. Psilocybin is mushrooms, you know, getting high on mushrooms. But now all the medical centers are rushing to open psilocybin treatment centers along with ketamine. It's a little scary, actually. Everybody's thinking this is the greatest thing since sliced bread, from what I can tell. Not that it may not be helpful, but I don't think this is a med that one would normally go to in this population, because what I don't know about is what do those chemistries do to neuroinflammation? That is never mentioned in these descriptions. Bipolar has a different focus. So you might see in depression, you might see a concentration typically here. In bipolar, you might see some areas like hypersexual, sleeplessness, insomnia, great ideas. So that's elevated dopamine. And in other areas, you might see decreased dopamine when you do brain scans. Similarly with serotonin, you might see elevations of serotonin in one area and decreased in another area. And it may depend on if you're in the high part of bipolar or in the low part of bipolar. The neurobiology also includes thickness of the brain, frontal, temporal, which is where the psychosis comes from, and parietal in the back. Lithium and Depakote, which are meds used for this illness, can protect neurons. They're actually known to support sprouting and growth of new neurons. Mood stabilizers, again, these are anti-epileptic, but they are also for mood, and most of them are approved for mood disruptions. They work on those channels, and they all say in their package insert, this works on sodium or calcium channels, GABA, but we really don't know what it does, but it works. That's what they tell you. And in fact, it does work on mood as well as epilepsy. Anxiety is a big one. Amygdala is hugely involved in anxiety, the hippocampus with memory. And there's a lot of connectivity issues between the frontal cortex and amygdala in terms of anxiety. And non-drug therapies also work to change the storage of memory, which is the hippocampus. So when you're doing certain types of therapy, they work to kind of rejigger your memory, like EMDR, if you've ever heard of that one. It kind of tries to reset your memory, or there's some particular therapies that try and break the chain of the memory and reconnect it basically internally in your brain that resets your memory for an event. Anxiety is huge in our population. These meds are very carefully used. These meds, particularly Ativan, make a lot of people very nervous. Some practitioners refuse to use them no matter what. I'm not one of them, but they're used selectively. They don't treat chronic anxiety. They treat specific like panic. And all of their action is increasing GABA, which is the calming opposite of glutamate, which is excitatory. And GABA is managed in those tubes I showed you earlier. A lot of you are getting this one, hydroxyzine, especially if you're going to the hospital. They give it 3 times a day just to quiet you down. Benadryl is in your closet, but you should know if your kid gets agitated on Benadryl or not. It's an antihistamine, but it also has a weak serotonin, that's 5-HTP, dopamine, and adrenergic receptor. That's that part that lowers adrenaline. Buspirone I like a lot. People don't know much about it sometimes. This 5-HT1A is a serotonin receptor that's really, really important in anxiety. Some of the meds you get, Abilify, and then one called Rexulti, which is kind of a newer version of Abilify, attend a lot to this receptor, which is one reason it works both for psychosis, but also for anxiety and for OCD. Here's adrenergic. I just mentioned those are the ones that change blood pressure and heart rate, adrenaline levels. Oxytocin has a lot of press about it, but it's just not ready for prime time. There's lots and lots of studies, but here's one, autism trial with nasal spray, 355 patients, which is pretty robust. No statistical improvement between that and placebo. Neurobiology of PTSD, amygdala disruption is huge because of the memory, and neurofibers are not connected to amygdala, are just not normally regulating as they should be. And in hypo, they have hypo, meaning underactive prefrontal cortex, where their amygdala, the anxiety part, is hyperactive. So the match is not happening between those two areas. There's some meds used for PTSD. Prazosin is used a lot for nightmares. Not always successful. I've tried it some in PANS. It's worth trying maybe, but don't look for it to be terribly successful. OCD, a lot of you have this one in your life a lot. Mice show excessive glutamate. That's the excitatory part of the chemistry for OCD. Treatments are all these meds, and some of them work, some of them don't. If you have what we consider a classic OCD with no sense of inflammatory going on, I'm not sure that exists really, but let's just pretend it does for a minute. You have to prepare yourself for very high doses. Prozac 20 treats depression, 30, 40 maybe for anxiety and depression. 80 is usually the dose you need for OCD. Similarly, Zoloft, if some of you are on Zoloft, probably 50 to 150. It's 200 to 300 for OCD. So one of the things it's really important to understand, and I try and tell parents all the time, is we're going high if we tolerate it. Probably 60 to 70% of kids in PANS can't tolerate high doses, but for the few who can, it's worth pushing out there to see if you can get any benefit. You can't see a lot of benefit with OCD if you can tolerate them unless you get to the high doses. Another one I mentioned was the TMS, the transmagnetic stimulation. Also approved is, very few actually, is approved for children and adolescents in this illness, Clamipramine. It's got a lot of issues in terms of blood management that you do have to have. You have to have EKGs. It can be a very good med. It's got a lot of side effects, so that's why you don't hear it mentioned much. Here's what we use and don't approve: paroxetine, Paxil, citalopram, escitalopram. Those are also being used, but they're not approved. Many, many, many meds that a child psychiatric person uses are not approved, FDA approved. It doesn't mean we don't use them, and it doesn't mean there isn't a lot of literature on it, but FDA approval only means it met for the company who made the meds safety regulations. They demonstrated in 6 to 8 weeks, not longer usually, that it worked different than placebo. That's all FDA means. It doesn't mean I can't prescribe it. It's an advisory basically. Here's the doses I was mentioning for OCD. Very high. This is schizophrenia. I'm not going to spend a lot of time on this, but psychosis is really important in schizophrenia. And very importantly, look at the areas. They're having abnormal neuronal formation, cell death is high, cognitive impairment, shrinkage of their brain is occurring if long-term untreated. The antipsychotics promote cell growth and anti-inflammatories. I mentioned some meds are actually anti-inflammatory. This is a good example. And many areas are overfunctioning, underfunctioning, particularly dopamine too. If it's overfunctioning, you get psychosis. If it's underfunctioning, you're socially withdrawn and, kind of flat, and your executive function's lousy. This is a list of old style we call first generation antipsychotics. This is the second generation. Many of which you might hear about. There's a lot of them. This is one that's given a lot. Not my favorite, Disparidone. It gives a lot of side effects, including huge weight gain and man boobs and milky breasts. This is a really good reference sheet for atypical antipsychotics. It's a little old, but it's still accurate for the ones you see above this from the Center for Medicaid, Medicare, or the CMS, yeah. This is third generation, which is the newer kid on the block, although Abilify has been out for 10 years. And these go towards dopamine 1, 2, and 3. And dopamine 3 is what everybody's kind of paying attention to right now. It seems to be kind of a magic area to hit if you can. Cogentin and Artane are things to help against antipsychotic side effects. ADHD, let me just say that ADHD, if you didn't have it before and now you got it with PANS, it isn't ADHD. It is hyperdopaminergic behavior. It is not going to respond to typical stimulants, so don't go there. And the neurobiology is here, I think, the best picture. Here's the control group on a brain scan with the fluid volumes I mentioned. You notice how it's kind of concentrated. This is the frontal cortex, the front. In ADHD, it's kind of in the back. Actually, I've seen other scans where it's like over here, over here, over here, but not concentrated down here in the frontal cortex. When you give a medication for ADHD for a person who truly has ADHD, which is deficiency of the dopamine flow, it now then lights up like controls. But in PANS, it's like all over the place and crazy in the middle here. And neither of these pictures are going on in PANS. What's going on is hyperactive dopamine, which gives you hyperactive behavior, inattentive, can't focus, and getting a traditional ADHD diagnosis, especially if you did not have it before 12, is inappropriate. I'll just say there. And nightmares, all sorts of things. Again, these are all the antidepressants. I mean, the stimulants, there's all different kinds. There's actually only two kinds. There's Adderall and there's Ritalin. But each week I get a new version of Ritalin. This is the latest and greatest. It's a Staries, which is basically Focalin times 2 in one capsule. So instead of Focalin 8 hours ER, it goes 8 hours, another 8 hours equals 16 hours. So many things you see coming out new are in fact just revisitation and delivery mechanisms, like little different train cars that bring you those medicines. A new kid on the block is Qelbree. Bothers me because I don't use it QE, not QU. This is a serotonin-like drug like Strattera. This is what Strattera is, serotonin norepinephrine reuptake inhibitor, and or selective norepinephrine, and it's once daily, maybe a little more potent than Strattera, but there's no head-to-head comparison, so we don't quite know yet. This is one I want to mention based on Gabrielle's comment earlier. Modafinil is really helpful for fatigue and alertness. It is a different drug. It works on the sleep-awake part of your brain called orexin, but it happens to have some dopamine, noradrenergic, norepinephrine influences, though it's not dopamine related. So if you're trying to get your child up and going during the day, this might be something to bring to somebody's attention. And this drug I love. It's Nemenda. It's an actual Alzheimer's drug, and you take it once or twice a day. It works amazing on working memory, which many of you all have trouble with your working memory. One of your kids are you. It is also really good for autism and social cognitive speech. So people who can't kind of carry on a conversation because all they want to talk about is what they want to talk about, that's partly because their working memory is so bad, they cannot retain what you just said to them, so they can't respond to you. And I think the simplest way to say is when one kid had this for me, his mother said, "It's great. We don't talk about dinosaurs every night at dinner anymore." You know, he actually will talk to his brothers about what they're talking about. So I use this a lot of different ways. It has actually got a lot of evidence for both adults and children that helps ADHD. It's really got like next to no side effects. So it might be something to bring up with the provider, and I can provide for you the articles that they could review to use it. And I mentioned Alzheimer's meds because I just wanted to bring that one up particularly. NSAIDs, please use them. Here's an article, a little old at this point, but it showed that without NSAIDs, that's your Advil, and Aleve, you have a lot longer time to recover from a flare. Here's 12.2 weeks without NSAIDs. With NSAIDs, if you got a flare on them, it was 4 weeks shorter. That's substantial. That's 3 months to 2 months. If you were treated within 30 days, not even if you weren't on them before, you had a 2.6 weeks shorter time than this group up here. So that would bring it down to 10 weeks, which is still awful. But believe me, they do work a lot. They really help in a flare, but you have to dose properly. This is the biggest mistake I see. People go, "Yeah, I'm giving one Advil in the morning." Well, Advil has to be 3 times a day if you're going to make it work. It's hard to do that. So that's when Aleve comes in, which is only twice a day. And also because you need to have food with all of this. I forgot to put that in here. You always want something in your stomach before you take it. You take naproxen or Aleve at breakfast and at dinner. That's simple. And set your alarms if you have to with a snack after school and then bedtime, because Advil is really great. And some people respond better to Advil than Aleve. There are some genetics that make Aleve and Tylenol kind of get eaten up quicker, so they don't last the time period that you're expecting them, whereas Advil is not bothered by that gene. That may be why some people like it better, but it does have to be given 3 times a day. Once in the morning is not going to make a huge difference. I mean, if you find it helps, do it, but you really want to try and do it 3 times a day. I provided you the dose ranges for both meds. And there's the issue about stomachs. Please stop if there's any belly pain. But people avoid this because they're really worried about ulcers. It's not common for kids to get ulcers. They sometimes get belly pain. We all do if you take it on an empty stomach. But they rarely, rarely ever get ulcers. Not so true with adults. And there's a reason for that I won't bore you with. Cannabis. A lot of people ask me about cannabis CBD. So let me just give you a brief primer. Cannabis, marijuana, has THC, which is the active component that's psychoactive, meaning it changes opiate receptors. It's got a lot more going on up there in terms of addiction properties, apathy that you can get, crossing the placenta, et cetera. And there was a warning recently out that the Delta 8 strain, which is what you see a lot of in cannabis product, it can be really problematic at high doses. And believe me, I've seen such paranoia and psychosis, hospitalized kids whose lives have changed because they went out and had oil or vaping really high Delta 8. And no surprise, it's mediated through benzodiazepine, which are your Ativan, Klonopin receptors. It's hanging out there with the opiates and benzos when you use THC. That's why it works so well and fast. Cannabidiol, however, is CBD, and it is not illegal to use CBD. The World Health has a long history about that. The United States has stopped even fussing about it. And there's a lot of reasons. In fact, there are 78 molecules that have been identified, and probably there's hundreds of more in our bodies. We don't even know what it's doing, not yet anyway. There's lots of work on this area, but still not supported by the government very much. But look at all the areas it can impact. That's serotonin, opiates, dopamine, 2 and 3. Remember I said 3 is really important. Glycine, sodium, and calcium channels. That's for your mood stabilizers. It's considered an anti-inflammatory. There's some really big articles now about that. And some of the doctors I noticed who are treating Lyme tick-borne disorders are suggesting CBD at low doses. And there are many different ways to give it. This was approved for epilepsy as a prescribed med. It's used for sleep, anxiety, pain, anti-inflammatory, maybe for acne. But there's 2 studies that have showed CBD in rather high doses, by the way, that helped on brain scan versus placebo with anxiety, for example. It also in schizophrenia showed that if you use THC in schizophrenia, it was a mess. But if you did CBD only, it was actually quite helpful. And there's an article here that reviews oils that you can get. It's delivered by oil flavored cheek patches. Most kids can do that. Some of the oils are pretty bad, even if they're flavored. Edibles, but you have to remember they're a lot longer to absorb and to wear off. So you have to really be patient and try if you're using them. And you start low and go slow really on this one. 10 milligrams per day, working up like every week by 10 or 20 milligrams. Don't be careful about going above 100 a day without really knowing what you're doing. I really suggest if you're going to use this, go to some experts who can, kind of help you modulate and pick out product that'll work for you. There's also low THC in some CBD products. It's not high enough to catch, the manufacturer being legal. But if you're involved at all in safety, like CIA or military or police, and you're being drug screened, if you have a really high sensitivity, you might come out positive if you're using only CBD products. Many of you ask about supplements. I'm going to make a couple comments, but they are listed here. EPA on omega-3. Not all omega-3s are created equal. You're looking for high EPA in terms of psychiatry. You might be looking for high something else with other illnesses, but psychiatry is clear. You're looking for EPA. You'll always get DHA with EPA, but don't have higher DHA than EPA. Just take it from me that that's the rule. Folic acid, which is Deplin, it's important. When I was at one of the last before we had COVID, one of the last PANS meeting in New York, at lunch, I heard could hear people talking about NAC and methylfolate at almost every table as I was walking to get lunch. There's a lot of misleading genetics about this. So if you have a homozygote negative, that's double homozygote, you have a problem transferring folate you eat to folate your body needs. However, most of us, 50% of us, have what I have, which is one works and one doesn't. You can just eat enough folate and it will get in. Now, I know there's a lot of people who tell you to have this product, 5-MTHF, which is the pure form. If you want to spend the money, be my guest, but you don't have to spend the money to get methylfolate. Only if you have the 10 or 11% of us who have no enzyme, you're not getting much. But notice that you get it in food you eat, including carbs. So if your kids are carb brave, eating carbs, they're getting folic acid because it's sprayed on every brain in the United States by law. If you have too much dopamine, this can be a supplement to try, but again, very gingerly try it. So if you go back to that list of high dopamine, you might try and see if this one will help you. Inositol is a great little thing. It's sugar, it tastes sweet. You can put it on cereal, you can bake with it. Anyway, divide it into grams, you can put it in cereal and smoothies, and it's anti-anxiety. It works in the benzodiazepine, the GABA area. DHEA is I don't understand a lot about it, but it's a hormone part of the hormone complexes. It can help. 5-HTP, that should not have a T in there, extra. This is a precursor to serotonin. So you cannot use serotonin meds and this med because you can cause a side effect called serotonin syndrome. It can also cause the same agitation, insomnia, mania, and thoughts of suicide as all serotonin drugs. So go slow and go careful, but it's a good thing to try for sleep and anxiety. These are other supplements used in more adults. Some of them, NAC, many people, that was the other thing people were talking about. It is not as great as it sounds, but it might be worth trying. Let me put it that way. There were some trials in adult OCD that really dramatically helped trichotillomania and OCD. The kids' studies have not held up. Carnitine is used for energy, and there are some people who absolutely, especially after viral infections, have a decreased carnitine level, but you can measure that before you treat it. These are some things particularly for sleep: passion flower, valerian, melatonin, ginkgo. I'm sorry, these three, but also with theanine, phosphatidylserine. There's some other things. A lot of meds I already talked about are used for sleep. So I didn't have one sleep film. I probably should have, but I didn't put it on one slide. Ginkgo is for dementia possibly and alertness. St. John's wort actually does treat mild depression, but it has terrible side effects with other antidepressants, migraine meds, some other meds. So you have to be very careful you're not doing med mix. Non-medication treatments, EMDR I mentioned, which is watching a bar of light or music instrument, rechanging how your brain is responding, neurofeedback. Vagal nerve stimulator, I won't get into that. ECT is still very effective for major depression. Exercise, even with a dog, get out, walk around the playground, get your child out and about, get some fresh air, get yourself out and about. A lot of people, when they're depressed, of course, are in their rooms and in the dark, and they don't want to move. They can't, they're just too tired. It's just achy. But just getting some sunshine and fresh air is really helpful. If you can get your kids off screens, remember that I talked about excess dopamine? Well, screens are very dopamine oriented. They continually push the dopamine. Every time you see something excited, your dopamine fires. So if you're on a screen all the time, playing games, constantly involved with electronics, you got a lot of dopamine flowing. So you may have to try and take a break. I get it when it's what you need to solve the problem of getting your child to bed at night or stop screaming or get them out the door for their appointment. Try and use it judiciously and try to strike a balance. Mediterranean diet and the DASH diet are hugely successful for treating depression, especially for the older people who can make some choices about what they're putting in their mouth. And also a very large number were found on a high inflammatory diet, which is all of our processed food, or as we call it, fake food, amounts of sugar, processed food, saturated fat. It's very pro-inflammatory. So if you're dealing with an inflammatory event, this is why people talk about gluten-free, dairy-free, because those are, especially gluten, are high inflammatory illnesses. Even doctors now in lupus, which is a huge anti-inflammation disorder, are telling people to go gluten, dairy, and meat-free. Some of the world's experts. And then therapy is really important, but truthfully, in a flare, you can't use it much because your brain's not working, your memory's not working, you're not processing much, and you can't think straight. So therapy is for people who can talk, who can actually consider what you're talking about. More often, it's for the parents to help support you than perhaps your child or you at the moment. You're really in a bad way medically with inflammation, but eventually it's a good thing to have if one can engage in it. There are kids with PANS, when you get them treated, they no longer have a problem, so they have no idea what you're doing in therapy with them. They have nothing to talk about because there's no problem anymore. When they're in a flare, there's a problem. So it's more giving you support to understand the means up and down of this illness than sometimes your child for therapy. And again, just like prescribers, find a therapist who has some appreciation of this illness and not undermining treatment. I had a kid who was going to see a quote OCD therapist expert. The mother gave all the information. I wrote this long letter about PANS PANDAS explaining everything. And within about 3 sessions, she told this kid, who I think was 12 at the time, you know, you really got a lot of anxiety, you got a lot of OCD, and I don't believe in that PANS stuff. So yanked him out, went to the next therapist. This is a great book for just understanding psychiatric medications, a lot of what I just told you. And consumerlab.com is a great place. It's about a $40 or $50 membership a year for any supplement you ever want to give or CBD products. They give you long explanations of all the tests and the studies that have been done. Say magnesium, they're going to tell you about what it's been tried on, what it's been shown to help with. And then they post what are actually good per price elements for you to order it. It's a really handy resource. And lastly, these are some interesting new books that you might want to think about. Mind Fixers, if you're interested in the biology of mental illness, that's more for people like me and the prescriber group. This Is Your Brain on Food is a pretty new book by Uma Nadu. I didn't know she existed. She's a nutritional psychiatrist at Harvard, of all places, which is not known for their kind of alternative thinking. And it's all about food and mood and OCD and anxiety and what you can eat to benefit or not benefit those areas. Then this one is about the glial cells. It's a great read. This woman writes really great. She's a reporter, and it's about the glial cells and how much importance it is in neuroinflammation. And then these two are really new. This one, Dr. Kaplan mentioned, and I got it. I haven't read it yet, but it's The Lady's Handbook for Mysterious Illness, a memoir. And this one is amazing. The Invisible Kingdom by Megan O'Rourke, which she talks about the problem with medicine when they don't know what is wrong with you. They say, go to a psychiatrist, and that's about all they do with it. And COVID now inviting people in to think differently about illness and mental health. But she writes one of the most exquisite discussions. It's pretty far into the book, but of the loss of self when you're suffering these illnesses. For you young adults, or people who are young adults, or teens who have been suffering for years, or with especially tick-borne illnesses that you rotate diagnoses, both medical and psychiatric, in these illnesses. The loss of self is such a huge part. It is often what leads to suicidal ideation and action, because you're depressed and you've lost your entire sense of self and your life and your friends and your family and your careers. And now what? So and then you've got inflammation, which makes everything like light up on fire. So it's really a beautiful written book about this. And I think she'll eventually be a really good resource for our community. And I'm going to stop there. I'm gone about 15 minutes over and see what questions we have. I'm sorry I didn't have a lot of time to go into some of the other stuff, but it's there really as a resource for you. If I gave you all those meds, you'll never remember them anyway. So now you can go back and have them as a resource.
Thank you, Peggy. I'm going to go through some of the questions that we had received earlier in the week. I know you were diligent in answering and incorporating many of them into your talk today. So it'll take me a little minute to pick through some of them. Do you think taking a low dose SSRI while pregnant may have contributed to my child's PANS?
No. Basically, there's no evidence that any medication in utero contributes. There's evidence that having a tick-borne illness during your pregnancy actually may transfer that illness to your children. That seems to be a thread you can see. What's more concerning, if you're seriously depressed and not on an SSRI, although there may be a little withdrawal, if you're on an antidepressant during pregnancy, your child may have a little bit withdrawal, and there's a respiratory syndrome that's not, doesn't cause death, but it happens to children when they're born. But depression during pregnancy and after pregnancy can seriously damage your generation and the second generation downstream. I didn't talk about that, but remember I mentioned changing genetics with exposures and environment?
Sure.
If a grandmother mice smokes, if you can imagine that, they can create that in a lab, 2 generations later, their children will have inattentive problems with not the second generation, but the third generation.
Thank you. Can the inflammation contribute to side effects from SSRIs?
Yes, very much. So nausea and headache and agitation. Well, first of all, agitation is, if you have a history, a family history of bipolar in the family, you are kind of primed to get agitated on SSRIs, but it doesn't mean you shouldn't try them. But you just have to be a little slower and more cautious trying it out. Nausea and headache, which are sometimes side effects of SSRIs, can be greatly exaggerated. The things you hear a lot about with SSRIs is it flattened them. It made them really crying and really moody and really angry, without the mania, without the hyper behavior, but their personalities just go wired. They're just off. And those can be on really small doses.
So
you still try them. Let me just emphasize, because a little bit of Zoloft can be very helpful to anxiety. But I used to get kind of like, oh, a little bit help, let's go up. Well, if I do that, it's really slow and cautious, because often as I approach normal doses, things fall off the tracks. A little bit helped, but not a lot. But then parents will go, well, if they're just on a little bit, maybe we should just take them off. And I go, okay, let's try that when nothing else is moving around. Because often there's things moving around a lot. You're changing meds, you're changing antibiotics, changing supplements. But if you can get a moment where nothing else is moving, take them off. But then parents go, that was a mistake. So even a little bit might be doing enough to keep it in place until more of the illness is recovered from.
And to piggyback off of that question, and it was going to be asked anyway, is when providers such as yourself talk about starting low and going slow, how slow is slow? Like what are we looking at? Because that could be very subjective.
Yes, exactly. In SSRIs, that's the antidepressants, slow is for 2 weeks, also with Wellbutrin. Here's why. The first week is often a great success. There's a flush of serotonin on those neurotransmitters that are getting attached, and everything's kind of rosy up there. And maybe it was deficient to begin with, so now you've kind of filled up the vessel. However, too much serotonin can trip you into the agitated anxiety part. So especially if there's a family history of bipolar, I never go anywhere in 2 weeks, because what I've learned is the first week may look great. And the second week is when they start to get aggressive, loud, bossy, disinhibited. Kids are mooning their classmates at 10 on the playground. They might be hypersexualized. They're planning parties that you can't pull off. They get very bossy. They're shaking their fingers in your face and ordering you around, which is not normal. But that often shows up the second week, not the first week. And the parents are like, oh, it was working so great. And I go, and then they go, but there's a new problem. And I go, what's that? And they go, that's the serotonin. They go, oh no, it was working so great. Well, it doesn't work so great as that serotonin starts accumulating in the brain.
So each med change of dose change would be a 2 week.
I would hold on it for 2 weeks. And I know you're going to hear prescribers go, go, 25 for a week and then go to 50 or something. But I would stay at I would say, well, I've been advised by some PANDAS experts. I really appreciate that idea, Doc, but I'm going to ask you to go for 2 weeks before we go up on the next dose.
And that's even when we're starting at those subclinical small doses.
Yes, yes.
So,
which may, of course, piss off the prescriber that you're telling them what you're going to do. Other family members just don't put it. I mean, even for me, people go, I go, we're on 50. No, I never increased it. They tell me, I go, why didn't you do that? Well, I just wasn't sure I should do that. I mean, this is a phenomenon we didn't talk about tonight, but it's really worth paying attention to. Is parents, you're all traumatized, and family members dealing with this illness. So you are going to respond in a fight, flight, or freeze mode as well. There's a whole biology around that. But confounding to me over the years, although Sheila Gouch has helped enlarge my understanding of this greatly, is that many of you freeze. And despite my direction, or, you don't do it. And you really don't know why you didn't do it. But it's because you're freezing and shut down. And if we all kind of just understood and accepted, I think I would be a better clinician for you. But you would also maybe be less harsh on yourself and feel less bad and not tell me. Because that's the other thing, is people often don't tell me they didn't do what I asked them to do because they don't know why they didn't do it. It kind of just slipped their minds, or they forgot about it. That was filling the prescription or going to pick it up after I've ordered it. Right. It's been surprising, but really interesting to me. And so I want you all to know you may be in that position, and so you just roll with it.
Sorry for interrupting. So then how do you balance those med changes if you do choose to go up in that dose when you're doing other medical treatments? Do you wait, or where? Yeah, how do you
there's a rule of thumb that functional medicine, I think, uses a lot, or people who use a lot of supplements, which is don't change anything next to anything else without 4 days in between. Now, there are certain meds I might say to people, yeah, go ahead and start X and Y at the same time, because I'm in a, the kids, we're trying to keep them out of the hospital. Sure. It's worth that risk to get them keep them out of the hospital, to start 2 things at once, to calm them down and to stop the OCD, because you're not always giving them the same med for that. Or knock the winds out of the aggressive sales, basically. But most of the time, supplements especially, you want to start about 4 days apart. Sure. Because if you take 2 or 3 and there's a problem, you have to start all over with each of those events. The other thing is supplements, particularly nutrients, take 8 weeks to measure. So you're not going to see much result until you give 8 weeks to it. So magnesium, zinc, calcium, B12, all those things take about 8 weeks to really see effect. And then people say, well, I wasn't sure it was doing anything, so I just stopped it, or I didn't get to the pharmacy, I didn't get over to refill it. And they don't realize, this is why when you stop and start things, including supplements, it's really important to put a date on it, because I might be able to connect the dots that you stopped omega-3 June 1st, and now June 30th, you're having trouble and nothing else changed.
Right.
And you didn't even realize what it was doing.
Yeah. I mean, I know as a parent, it's hard to tell.
Oh, it's very hard to tell. It's often Aunt Jane who comes over and say, what happened? It's not us who recognizes it. And that's right. A parent. That's being a parent. That's nothing particular to you or anybody else.
Yeah. And then if you're one of the parents with 2 kids with PANS at the same time, your brain is really in 5 million.
Oh, and the volumes of papers and journaling I'm asking you to do is huge. Right. I mean, some parents who can do it, and I'm not great on the computers all the time, they do spreadsheets, and it's very helpful. Because then they just print off the latest spreadsheet and hand it to me, and then I have to figure it out.
Yeah, it takes practice to get that kind of discipline down, but it does help. So you spoke a little bit about the OCD meds, but do those specifically help so do some of them help the intrusive thought process more?
Yes. But the intrusive thought process in PANS is a little more problematic than straight up OCD. All OCD is intrusive. It's not a pleasant idea. And if there's an action, which is the compulsion, it's to divert the intrusion or to interrupt the intrusion. So if you've got dirty hands, you wash to relieve the sense of dirt and contamination. But yes, they do. And serotonin most of the time is inadequate in OCD brains. In PANS, the serotonin distribution, I think, is way off. It's not that you don't have enough sometimes, it's as your body is producing it, but it's not impacting the area of the brain it should. So the fact that for as long as I can remember, high doses of serotonin are used to treat OCD. And if you don't use high doses, again, in classic OCD, you're not often going to get effect. So that is about intrusiveness. But the other really critical thing in OCD, again, classic, is exposure response therapy. Now, again, it's very helpful in OCD PANS if you're not in a flare. If you're in a major flare, it's useless. But if you can start to develop a relationship with an ERP therapist, particularly the parent, by the time you get into these therapists and see me, you're so hooked into the ritual, especially if the child is confessing, touching, you're the manager of their OCD and you get all the rage, just to remind you. When you interrupt or don't help the OCD in its cycle till it feels right, you have tremendous rage against you. You can have a lot of aggression with OCD, not just this picture of frozen people and washing their hands away. If you try and drag them away from that tank, they may smack you or they may punch you, because it is so critical that they do this. And also I've been seeing shoplifting and stealing, because the kid has to have the latest Pokemon or the latest Minecraft, or that, they take your credit cards and spend enormous amounts online because they have to have something. Now, this is different than perseverative, which is I have to have pleasure to manage my anxiety, and because that's the way I manage it. Perseveration is in the business of pleasure, but you don't go break the law to get it. When you're thieving because your brain says you must have it, that is OCD. I don't know if that's clear, but you can be like, I have to have the latest, greatest shoes or tennis shoes, or boots or something. And I'm anxious and I like that. That makes me feel better. That's perseverative, but that is not just OCD. Right. But when it's intrusive, it is really intrusive. There's no blocking it. So if you can teach kids how to block it, distraction is a great thing. This is why they often do better in school when they're awful at home, because it's distracting. It gives them something to do besides think about what's going on in their brain.
And so to that end, when we talk about that pleasure area that falls under the perseveration, when we have kids who spend too much time on screens with their games, and people say, oh, we can't pull it away because that's the OCD, but often really, do you think it's more perseveration or screen time?
Yeah, I do a lot. I think especially in the autism group or ADHD group, because for people with ADHD, their brain is so easily bored. I mean, that's part of the illness, or I don't call it illness, condition, let's say. They need stimulation, and school is really darn boring, frankly. If you think about what you're learning in a day, it's not terribly exciting. But give them an interesting topic or an interesting teacher, they're fine. Put them outdoors with rock climbing or challenges, or jumping off of barn roofs with their skateboards, they're fine. Give them a computer with a game that always has a new rocket ship going off, or a new formation happening, or a new fight. Their brains are happy, happy, happy with dopamine stimulus. Mm-hmm. And because remember, I showed you in the brain where the dopamine wasn't working. Yeah. When you stimulate it correctly, it's now in the frontal cortex. Dopamine is always working fine when you're interested. It's when your brain is not challenged, when it's just sitting quietly, or boredom in school, that it's not lining up correctly.
All right. So what is the difference between Lamictal and Topamax? Have you found one over the other to be more effective for treating intrusive OCD thoughts?
Neither. But let me give you a couple pieces on that. Both of them are the anti-epileptic meds. Lamotrigine is used and approved for bipolar II depression, I do use lamotrigine for depression in this illness state, especially the depression you see in tick-borne issues. It doesn't have many side effects except a very, very, very serious rash that you have to be coached on in case it shows up to stop it immediately. That's when you stop immediately if you see a rash until the person
That
gets
usually
to
gets
what kind of.
titrated up really
Yes,
slowly.
it gets
like,
real slow.
good
That's
job.
one of the problems with it. It takes 5 weeks to get a minimum dose, and you may not have 5 weeks to spare. Topamax is another anti-epileptic. All of these are used in epilepsy. It at high doses has even at low doses sometimes has what's called word finding difficulties. Like you're thinking about that place with the crown that you're going to get a burger and it's gold and blue if I remember right, and the tip of the tongue, it's Burger King, but you can't remember to say it. That's called tip of the tongue.
Mhm.
And that can cause word finding problems can be a problem. Weight loss is a big problem. Now, if you have I've used it for weight loss actually, and it is part of a new drug that's come out for weight loss. It's partly Topamax. But it's contraindicated if you have a history of kidney stones. There's some other things you need to know about it. It's kind of a third tier antidepressant, but there's no indication that either of them work for OCD. What they do is work sometimes for anxiety and depression. And that's how I think of them, not for OCD. But if you in this illness in PANS PANDAS, you don't usually always just only have OCD. You might have hell of a lot of separation anxiety along with that OCD. Now, part of that's because your parent may be part of your OCD ritual, but some of it's just sheer terror of leaving the house or leaving your parent. And the kid and the adult doesn't necessarily know why they're not leaving, but it's clear they're not going to be able to do it easily.
Yep, very clear. All right. Hope you answered that. You answered that one. If PANS and PANDAS is suspected but not completely confirmed, how do you approach using psychiatric medications for OCD and anxiety, knowing that maybe this is the issue or part of the larger picture of PANS?
Well, I don't have to know it's got a diagnosis of PANS to see and experience to know what the symptoms of the OCD and all the accompanying stressors are with it. So you don't have to have anything but OCD or depression as evidence to treat. You can be, in fact, it's very common when you go into a place that, like in my private practice, I did medical and psychiatric. So while I was waiting for the blood work to come back, if you had a person that was really going out of their mind with OCD, we would start treatment. I wouldn't wait for the lab work. Parents would come in to me and beg me, please do something because we're going to Disney World and they are raging and we are all going to be totally distraught if we're going to Disney World and get them on a plane and get them off the plane and, please do something. And then we have a long discussion about atypical antipsychotics and what the risk and benefits are, but if they're willing, they can try it because atypical antipsychotics, to be frank, are chemical restraints, but sometimes you need that restraint so you're not in the hospital. Or that you can actually get out the door, or you can actually be at a relative's house and not tear it apart. I mean, there are realities about what these meds do, but I'm not shy about saying they're a chemical restraint. I often say to kids and families, I say to kids, especially middle teens and younger, slightly younger, you're like a firecracker and your fuse is way too short. And this medicine's going to give you a lot longer fuse so you can kind of pause before you blow. And that's what happens is it kind of gives them some space to not just blow up, in that tiny little fuse they're carrying around in their head.
Right. I mean, the PANS PANDAS guidelines, treatment guidelines, in that part of that triangle, it says the purpose of these meds is to decrease suffering and to help with compliance. And that compliance part is sometimes that chemical restraint. So you have to. And unfortunately, a fun choice.
What I find in all guidelines about PANS PANDAS is that the psychiatric component is pretty left out. You get a little message about a serotonin reuptake inhibitor, that's Prozac or Paxil, SSRI. That's about it, which leaves all of you kind of clueless and not at anything your own fault with Well, what does that mean? Because it doesn't usually, as I've talked to you about it, it doesn't always work with SSRIs. In fact, even if you don't have PANS PANDAS, SSRIs, a dirty secret of SSRIs is only about 33% have good response. If you're depressed, about 33% have a wonderful response. About another 33% have like, okay, I'm not depressed, but I'm not happy response. You know, you took away my depression, but I'm sure as heck not having happy. I don't feel happy. I feel flat, or I just kind of go along to get along. And another third have no response whatsoever. Some of that's genetically driven and some of it is not defined yet. But so I have, because they are unfortunately the main med for OCD. The other thing I use a lot for OCD, if you blow out of serotonin drugs, is Abilify, Seroquel, sometimes risperidone. There's data that helps that area. And I've had kids who on SSRIs, tiny doses, went totally Looney Tunes. One girl had it at 8 in the morning. She was laughing like a hyena in Spanish class by 2 o'clock in the afternoon. Now, she was unusual, but it happened several times on different ones. And I just put her immediately on Abilify, tiny dose, and it really kind of took it away. Now that was great because it wasn't a whole lot of work to get her healthier, but so this is the other thing, is a lot of people, when they hear atypical antipsychotic, are very frightened, and you listen, you look at the side effect list. It can be frightening, but the rate at which those frightening events happen are not on these tiny doses. Those are on doses for bipolar and schizophrenia.
Okay. So you talked about titrating down. So say someone is going off and knowing how to get down off of it if it's not working for them. Do PANS PANDAS kids, are they more prone to have issues with the withdrawal and coming off of them? So getting more.
Not that I see. No, I don't see that. No, I don't see that.
Good to know. And then as you're going back to that question about titrating up, how do you assess if you are at the optimal dose?
Is it working? So there's a saying in all stimulant dosing, treat to effect or side effect. And I'd say that principle applies in a lot of them. There are certain ones, insurance just won't pay beyond a certain point, just to be matter of fact about it. Or they have these stupid ideas. If it's 2 pills a day instead of 1, they're not going to get approved for it without a prior authorization. I mean, there's some really squirrely rules. Like I have a kid who's got PANS PANDAS. She got a really good benefit out of a little bit of an antipsychotic and a little bit of a Prozac. But I thought I would get her off the antipsychotic by giving her more Prozac. So before I take you off of 1, I'm going to give you a little more. She went from 15 to 20, not much, because remember I told you 80 is the high dose on Prozac for OCD, traditional OCD. She went to 20 and she fell apart. I put her back down to 15. She's perfectly fine. We lowered the Rexulti, which was the atypical antipsychotic she was taking, but she couldn't get off either. But each time, and I've tried about every year, we try and come off a little bit, she starts falling apart. Now she's still in that high risk for strep. And in fact, she had strep, her brother had strep in the last 2 years, I think. Although with PANDAS, we had a lot less strep, but she got strep right as COVID was starting, and she had a really bad flare. Not very long, by the way, but her med is the darndest thing for me because it's a pill. You can't get a capsule of Prozac at 15. And I have to fill in paperwork every year, extensive paperwork, to talk to 3 or 4 people because they don't understand why I would need a pill for OCD at 15 milligrams, because I have to cut it in half as a 10. I mean, it's crazy making. And the problem with providers is we don't have time to do this. So a lot of people just won't order what you need because they're not going to do the paperwork. Too much work. And this is part of the problem, is newer meds, which are often cleaner. They often have less side effects. Some prescribers, medical and psychiatric, won't do the paperwork for you to get you it. IVIG is not that you don't get it, but IVIG requires a lot of paperwork, a lot of effort with insurance companies and arguments, and it makes it really hard to get it. hopefully in Massachusetts with legislation that requires insurances to get it. But that doesn't mean they're not going to put you through the hoops. They just can't deny it ultimately as easily.
Right. You just have to have a provider that'll jump
Yeah.
through all of them.
And the question is always, how high do we have to jump?
Yeah. And how many times?
Mm.
So, since not everybody has access to you, there are questions on who else can they talk to. So if they have gone through a couple of psychiatric doctors or nurses, such as yourself, can other types of PANDAS doctors manage this, or an LLMD, or their pediatrician who seems to be on board?
Pediatricians will often do a small amount of these meds. They're very familiar with Zoloft, Prozac. Some pediatricians will not do any SSRIs, by the way. I've found out more recently. I mean, it's frustrating.
Yeah.
But I think a trick to this is, especially with pediatricians or family medicine, you don't talk about the PANS PANDAS. You just talk about the symptoms. You know, you talk about the anxiety, the OCD, and they'll do their beginning. They never go aggressively high. That's not their thing on any psychotics. So if you can get them to start something, they're usually going to go low and slow anyway, because they don't like high on these meds. They don't feel comfortable. They're not trained for it. So I appreciate that.
Will they go low enough? Start low enough?
Yeah. And you can always, you know, if it's Zoloft 25, cut it in half.
Okay.
Or ask for the liquids so you can titrate it much easier. And Prozac liquid, by the way, is god awful, which is one reason I don't ever hardly use Prozac in tiny doses other than a 10. You can, if you get the pill, you can cut in half, but you can do 10 capsule every other day, and that equals 5, by the way, on Prozac. Prozac's a very long to get out of your system drug. So if you give a 10 every other day, you're getting only 5 a day. So that's one way you do it.
Okay.
But liquid is god awful. The other one that's liquid's god awful is Augmentin, by the way. If you can get a kid to drink that, they're amazing. But that limits your use of it if you're not swallowing pills. Oh, there's something I should have put in here. At kirkmanlabs.com, there is an amazing list under the FAQ. That's kirkmanlabs.com again. They specialize in supplements in the autism neuroatypical group, but they've developed a real expertise in how to get meds into your kids, how to mix them and hide them. And so under the FAQ, they have that list if anybody's interested in that.
One drug you didn't mention, I think, because there was a lot in there, but what are your thoughts on LDN, low dose naltrexone?
Oh yeah, I have not been giving it much. I mean, I follow it if it's ordered. It's mostly used by the Lyme treaters, the tick-borne illness treaters, not so much. Although I did see it, I think maybe in Stanford they're giving it out. Jenny Frankovich, maybe, I can't remember.
I know down the road from you, Zangers gives it.
Oh, Julia. Yes, Julia's been writing in her notes. Julia Zhang, for those who don't know her, she's a rheumatologist at Tufts Medical Center. She's been ordering it, and I've got to actually find out from her what angle she's coming from. So low dose naltrexone is an anti-opiate. This is naltrexone Narcan, but low dose apparently has some anti-inflammatory properties. It can be put on, I believe, as a cream, which is another advantage.
Right.
So it's one I have to look into. Yeah. Oh, one other thing about this stuff, you have to be careful also. Some parents get really excited about all the supplements, and you know, they'll get the book like Dr. Nadu's or something. And when you've got a mix of supplements and medication, you have to be careful not to overwhelm your child, because one day they're going to come out and say, I'm not doing any of that. I'm done.
Absolutely.
And then you're going to be up the creek, because if you don't get their regular meds into them, that includes the antibiotics and the Advils of the world, not just psych, you are really in trouble.
Right.
And so be a little careful how rigorous you're giving supplements. Now, some of you go to functional medicine people and they want you to give all these supplements, and they hand you long lists and they sell you all these things. That could be a problem for a kid. And parents often used to bring me these pictures of all the supplements lined up on their counters in the kitchen, on their bars. And about how many different pills they're managing all day. Because I'm saying, well, can we do this one? They go, oh my God, I'm not calculating how many other things they're giving. But I just want to caution people, sometimes you just have to do the bare minimum if that's necessary. And no matter how much we think it's better to give a zinc and a calcium and a magnesium and some NAC, they're less important than the antibiotic, let me just assure you, and less important than the Aleve.
Right. And I have found, because we have gone through pill fatigue in our house for sure, is you have to have that conversation with your provider of, and the patient, when they're able to really absorb the information, because sometimes they're not, when they're really, really super sick, but coming up with a plan to almost triage what you're taking. So we're doing all of these now, and then we will reevaluate. And if I can only get in one pill, what is it going to
Which one is it? Right. And sometimes I sit with parents in their long list and I go, 1, 2, 3, 4, this is the priority of these meds. And sometimes I can go, you know what, this med in psychiatry, give it every other day, every third day. Because, it can kind of like Prozac, you can kind of get away with sometimes giving it every couple days if you have to. Abilify, one that many people get, is people are known to miss several days before they start to notice sometimes. Although sometimes on tiny doses, you take away just a tiny bit and you notice right away.
Right.
That's very individual. It has a lot to do with how you digest it and how your body manages it.
Yeah. Right. And, in all the tracking, it does help to try to track, like, well, we really aren't giving this at the full dose, so that when there are those changes, the doctor can help review those. It's hard to keep track of all that. I mean, I've been there.
And also, I mean, I'm really constantly, but I sometimes even forget myself, who's been sick? That's the other thing you need to record all the time. Who's been sick? Who's been exposed? Joey's fine, who's the brother of your kid, but his best friend has strep. Well, that could be a problem, the head cold that's been going along with COVID, or the stomach virus that's going on last fall, in addition to COVID, they matter. People come, I always say, but parents will call me and they're going on and up, but the kid falling apart, and what was the med, and what did we give him or didn't give him, and the parents coughing, and I go, for 2 minutes you've had about 15 coughs here. Oh, it's just this little cold. I think it's allergies. And I go, maybe it isn't to your child's immune system, such a little thing,
Right.
And then if a cold's going around the family, I say to people, I'm sorry, but until everybody gets over their cold for 2 weeks or so, this flare is probably going to go on. You can't dictate to your immune system what's going to happen when you're constantly bombarded by everybody's germs.
Right. Absolutely. And it just depends on if your kid, and it's hard to tell when that's going to be, because you can say, my kid only reacts to this. And then down the road, we find that that blood-brain barrier, our immune system, they start reacting to more.
I haven't put this in the list, but this gets me into my functional hat, which is, there's some, if you've got, and Dr. Bubolis really hones in on this as the allergist down in Connecticut. If you have allergies, if you have food sensitivities, you need to tend to those. I've had some people who I keep going, give this Zyrtec, because they're not sleeping, because their allergies are horrible in the spring.
Right.
If you don't sleep, your immune system's shot. So you've got to tend to some of the basics around, just other sources of inflammation and infection. And if they've got rashes, or if they got psoriasis or eczema, those are inflammatory, of evidence of inflammation going on. And so you have to try and get that allergen stuff down.
Yeah.
And so things like people take monolaurin, which is lauricidin, another one that tastes awful if you chewed it. But that's purported to have properties that are really good antiviral. Another one is the colostrum, Ken Bach's area called For Life. But colostrum is cow's milk, baby milk, just like mothers, but it doesn't have the dairy protein in it usually. And you got to make sure it doesn't when you buy it. But it carries all these antibodies that the cows got from their mommies, who graze on, grass and soil, and they get all these they get all these exposures to germs. And so that you're passing along immune stuff. Now that stuff, colostrum and monolaurin, you have to wait a couple months. And so parents will often start it like in the fall, and they would tell me in the spring that they've never had such a great allergy season. In other words, it does have a downstream impact. But again, if you're adding colostrum, you're adding monolaurin, these are, and turmeric's another one, you know, antioxidant and anti-inflammatory. You have to be really patient, and sometimes you just don't know if they're going to work or not. Right. One thing about turmeric, which is known in many places as Mariva, it's one of the product lines, it can interact with some meds. People don't know this, but Zoloft and turmeric, Mariva, sorry, curcumin, I should say curcumin, the product of turmeric, have a drug-drug interaction. And so you may be blunting the serotonin by using the Mariva. So if you have a supplement and you're not sure about the med, Google it, because somewhere in the internet, probably someone has said about it.
So would curcumin and 5-HTP have an interaction?
No, not particularly. It's serotonin, which is a different, Zoloft, but it's not, it has to do with a liver enzyme called 2D6, 2B6 for Zoloft. Okay. Another one is, it can interfere with a lot of anesthesias, Mariva. And this is one reason they tell you to get off all supplements before surgeries, is because some of them, you know, omega-3s theoretically can cause blood thinning, but I don't even know if anesthesia notices, but curcumin can interfere with some anesthesias. Right.
So for the anti-inflammatories, we talked about the Aleve and the Advil and how it can shorten that particular flare. And so that would probably be, or most definitely be, one of the things in our toolbox to start right away before we're like, oh,
absolutely. Before you even get to a provider, get it out and start it. Yeah. And so, be good about giving it. That's the thing that people fail in the most, I'd say.
Right. Yeah. It's definitely, there's concern, you know, we see that in the parent groups.
And crush it and put it into things or drizzle it on, you know. If you're getting liquid though, try not to get the red dye part, because that's excitatory. That's highly excitatory in the brain, is red dye. Blue dye, red dye, for a lot of kids, especially young kids. But you know, crush it, put it in whipped cream, ice cream. The trick of giving meds is to coat the tongue with something somewhat thick, not peanut butter, but like chocolate, pudding, whipped cream, ice cream. Then take the med and then recoat it again with the food you're giving. Melted chocolate chips. You can make little chocolates with melted, you figure out your microwave count to make a real creamy smooth, and then drop the pill and crushed pill in there and zip it up, you know, stir it up, throw it on a piece of wax paper into a glob into your freezer. 5-10 minutes, you got a chocolate med. Now it doesn't mask it entirely, but if you start with some chocolate, and with chocolate, you can sometimes get it through. Some kids tend to love whipped cream. It kind of masks everything. You can put the pill right in there and they just swallow it. It just like floats down with the whipped cream.
I don't think anything masks the taste of Advil though.
No, maybe not.
It's the most horrifying experience.
But you can do liquid Advil. You know,
yeah, exactly.
Motrin.
And luckily there's the dye-free Motrins and everything.
Right. Yeah.
Okay. I think a lot of the other questions are really very child specific, which I know that you don't want to answer. But you covered, I'm glad we sent you would have covered them anyway, but we collected all the questions ahead of time and sent them to you. So I think 99% of them are in there. So thank you so much for this wonderful talk. And it was really informative. For those who, I know will be note taking. So this video will be available in about a week or so. I do a couple things like during these questions and answers, I put in a slide with the questions. So it's sort of easier to find. And if you want to date stamp, time stamp it and say to your husband, listen to minute 23, it's easier to find, but you can pause them and take notes. So even on the pages that she went through fairly quickly, you will be able to access that information. It, depending on my schedule, it can take about a week. Sometimes I get it done right away. but it'll be up there under the same link that you went to on the Aspire site. I will take down the register now and replace it with the actual link.
And
And
I just want to say, I know I put a lot in this lecture and I didn't cover a lot of what I put in there. That really is for reference, because I decided ultimately I needed to give you a lot more advice around just what it is to get kids medication and being prescribed these meds, because those are the areas I find are the weakest links. You can always go and get a doctor to give you a prescription, but you want to be prepared for that process as best as you can be. So I know for some people, they might have wanted specific things about different drugs, but you can look that up. There are books written about that stuff. What you can't find is a person who's treated PANS PANDAS and the specific hazards of that and the specific benefits of knowing what you're doing with that. So, and again, I know that there aren't a lot of providers out there. It's really hard. So it depends a lot on you as a parent to try and find somebody who's kind and gentle enough to work with you. They may not be a PANS expert, but that may be the best you can do for the moment. So.
right. Thank you very much. And it was wonderful to spend time with you. I do miss
Thank you,
you and all
Gabrielle.
the time I got to spend with you at NPANS, but I'm so glad that you have not retired. It is a major blessing, and it was a big fear of mine that you would. I was like, no, that can't happen. And I'm so grateful that you're hooked in with two wonderful, wonderful women to do that with, and you continue your work at NPANS, and we're so grateful. And thank you very much. And thank you to everybody who came and listened. And if you tune in via the recording, thank you for listening to the recording. And we are around. Thank you.
Thank you. Good night.